Hi, everybody. Welcome to our Diabetes and Fertility Talk. It's an honor and a privilege to have one of my favorite people in the world, Leslie Kerr, to discuss this hot topic with us. Did I say your last name right?
Yeah, I still don't know my correct last name anymore, so it's totally good. Thank you.
Yeah,
I'm happy to be part of this today. Thanks for inviting me.
I've missed seeing you. I know COVID has changed our, you brought me the best lunch I've ever had. Thank you so much that day.
I owe you one.
This is such an important topic. I think, it's not talked about enough, and this is like an opportunity for us to answer questions. And it's given me a chance to really look at the scientific literature out there and think about it a lot. And I'm so happy to be here with all of you guys today. Next slide. So we're going to just talk about our group here at Southern California Reproductive Center in Los Angeles and discuss our embryology lab, as well as go over some important information about diabetes and fertility. We're happy to answer your questions, and we'll discuss an offer after for new patient consultations for my whole wonderful group. Next slide. So I was born and raised in LA. I went to UCLA for medical school, and then I lived in Baltimore and went to Johns Hopkins for residency and fellowship. And then I was blessed to come back to LA and work at Cedars-Sinai as associate residency program director for almost 8 years. I love to teach, and I've been in private practice now for 8 years. And it's been such a wonderful journey to help women and men and couples, everybody, have healthy babies and freeze their eggs and talk about protecting their future fertility. And again, this topic's so important. Next slide. Our group has been here since 1999. We have a lot of wonderful teammates that we work very closely together. And our group works collaboratively, and we all provide very individualized care for each of our patients to go the extra mile to get healthy embryos and get you a healthy baby. Our office is in Beverly Hills. We also have a fantastic new office in Pasadena. Our embryology lab is here, as well as in Santa Barbara. We have a wonderful embryology lab there that helps a lot of patients from Northern California too. Next slide.
Can I just say that your office looks like a spa that I want to go to?
We tried to make it calming for patients, and now we have acupuncture downstairs, who's so fun. She did a session on me, and I felt like totally like my cortisol went down. It's so nice, and we're just trying our best to make the experience the best it can be for everybody. Our lab director, Dr. Jason Barrett, is a PhD. He runs a very tight ship and keeps us all in line to get the best success for the best quality eggs, the best quality sperm. And we have a double witnessing system. So every time eggs or sperm are touched or an embryo, there's 2 people monitoring everybody. We have blastocyst culture, where we grow the embryos for 7 days in the dish. We freeze the eggs with something called flash freeze or vitrification, which helps us get the best thaw success. Around 93% of the eggs survive the thaw, and 99.6% of embryos survive the thaw. We also were one of the first to do genetic testing on embryos. We now do testing on day 5, 6, and 7. We take 3 to 4 cells off the 100 cells, and we can check for all 23 chromosomes and specific genes like sickle cell disease, cystic fibrosis, early Alzheimer's gene. We can check for specific things depending on your specific scenario. We also help patients with family balancing if they want a specific gender. We have an embryoscope, which is a state-of-the-art embryology lab technology that allows us to monitor the embryos over the 7 days with 1,000 data points. So if we're blessed to have 2 good embryos, the team can spend 3 hours monitoring all those data points and decide which embryo has a better chance to stick and to be a healthy baby. So it's really been helping us. We have an abstract at ASRM showing that women over 38 whose embryos go into the embryoscope, that we get more blastocysts, which is more of those stronger embryos, and that actually gives us a chance to get another chance to get a pregnancy. So that's been a really big, exciting new technology over the last few years.
And I know you're going to show a slide on that, but we actually did that with one of our egg retrievals, and it was pretty cool to watch.
Yeah, that was so beautiful.
Yeah.
Next slide. I'll pass it off to you, Leslie.
It's all about me. No, I'm kidding.
Yeah, I love
Hey,
this
everyone.
picture.
I'm Leslie. I've been living with type 1 diabetes for 40 plus years, and I'm really passionate about helping women that are also dealing with type 1 diabetes and trying to get some information around fertility. One of the things that I think was most concerning to me is when I was starting on this journey, I didn't have the right people in my life to push me in the right direction. And so, of course, I turned to Google, which is probably what everyone does, to look up type 1 diabetes and fertility. And the results that I got were disappointing and not enough information, and kind of sent me down a rabbit hole where I knew what I was looking at wasn't the honest truth. And so I knew that I needed to have the right endocrinologist and the right gynecologist in my life in order to point me in the right direction. And luckily, when I made those two changes and they introduced me to Dr. Alexander, all of that kind of came together for me. So that's really exciting. And that's one of the reasons that I love partnering with Dr. Alexander, is that, you know, she gets it. She understood my struggle, and we worked together to find a plan that worked for me as a type 1 diabetic, not just any other patient, because things are a little different with type 1 diabetics. We have to worry about what does our blood sugar look at like at the time that we're doing things, and what is this medication going to do to my blood sugar, and how is my fertility compromised as being a type 1 diabetic, because I see plenty of type 1 diabetics having babies. Why is it not happening for me? And so it was really invaluable to have her on my team to work through this. And as you guys see, I now have two beautiful, beautiful kids, Elliot and Holland. Elliot is about to turn 4 and Holland is 1. And both were a result of my work with Dr. Alexander, or the work that she did on my behalf to make sure that I was able to have successful pregnancies. So a few of the things, I just want to talk about a few of the things that I've been through. It feels like I've been through much more. I was trying to list everything out, and I thought no one wants to hear all of that. But everything starting from some initial testing with an old gynecologist for years, who kept telling me to just keep trying, just keep trying. Around 36, I realized this just keep trying thing is not working anymore. I need to figure out what's going on. So definitely encountered some pregnancy loss, did some cycles with Femera and other drugs, found out through an HSG that I had a blocked tube, which led to discovering I had stage 4 endometriosis. So the list kind of goes on and on and on. And throughout all these processes, having the right gynecologist and having Dr. Alexander on my team helped me get to a point where I could actually get pregnant and stay pregnant. So that kind of brings me to this moment and my beautiful babies, and also makes me think about what all the other women that are like me that are going through the same thing, and what kind of concerns do they have, and what can they not find on Google, or what is their doctor not telling them that they probably need to know about. And so I asked Dr. Alexander if it would be okay to share some of those questions that come up in our community. So I'm hoping that we could touch on those next.
Yeah.
Next slide. So the first question that that I see asked a lot is diabetes and egg quality or quantity. Like, are there any impacts? Because I knew that I was kind of a PCOS type person because of taking so much insulin. So what does that look like? And are there impacts to egg quality if you have diabetes?
Sure, I think that's such an important question. Well, with diabetes, especially type 1, there is an increased risk of anti-ovarian antibodies, which are
that was me.
antibodies that can affect the ovarian function and reserve. It's not a perfect test because it can ebb and flow, so it's not a constant antibody response, and it can cause our egg quantity to shift at a younger age than we would kind of expect. I think having a high hemoglobin A1C causes inflammatory cytokines, and that can impact egg quality too. So it's important whether someone has PCOS or type 1 diabetes or type 2 diabetes to try our best to keep the hemoglobin A1C as healthy as it can be.
That makes sense. I was definitely in that category of the anti-ovarian antibodies. So yeah, that's very important. How does insulin resistance affect fertility? So let's say you're having to dose a lot of insulin and you're having a lot of insulin resistance. How does that affect things?
That's a really good question. So insulin growth factor 1 receptors are in the ovary, especially in the cortex, which is in the center part of the ovary. And so the more we have that activation, there is theca cell hyperplasia. So the inner part of the ovary gets a bit hyperplasia, and that can look like PCOS. So that's why the follicles get kind of pushed out to the perimeter. And so insulin resistance, the way I think about it is that it may impact the maturity of the egg that's ovulated. And so sometimes patients say, I've been trying, I'm young, I'm, getting a positive ovulation predictor kit. I feel so frustrated. I don't know what's happening. I'm not getting pregnant. And sometimes it's that kind of gentle push to get the follicle to be more mature. And then our diabetic patients get pregnant. And so it's an interesting little nuance there.
And I feel like the next question kind of goes hand in hand with that, with insulin resistance. So how important is my A1C? And for many of us that are type 1 diabetics, and I don't know what the number is for diabetics, type 2 diabetics, but lots of us deal with thyroid issues, especially later in life. So what's the importance of having a good A1C? What does that look like? And what about keeping the TSH levels looking good going into fertility treatments?
I'll start with the thyroid because I think that's common in women. All of us women it's very common to catch subclinical hypothyroidism where the TSH is a little bit high. The TSH is produced by your pituitary gland, and it tells your thyroid gland, okay, please cooperate and make thyroxine or free T4. And so if your TSH starts to go up and your thyroid's like, haha, I'm not listening to you. And so it starts to push towards hypothyroidism, and hypothyroidism can increase the risk of miscarriages, egg quality issues. It can cause weight gain, fatigue, dry skin, sleepless nights, memory issues, constipation, things like that. And so it's important to check your thyroid and keep your TSH if possible, chat with your doctor, but below 2.5. We also catch autoimmune issues in type 1 diabetics, such as anti-thyroid antibodies, but they'll have a normal TSH and free T4. And even in that situation, it may be safer to be on a teeny dose of a thyroid medication to also lower the risk of miscarriage too. That's a little controversial, but that's a discussion with your doctor too. The perfect hemoglobin A1C is very hard with type 1s because I know from my own brother and from my family and people that sometimes it's hard to get it down, and we actually don't want to get it too low because that can mean that you're having very low lows. So with type 1s, I rely on the endocrinologist to kind of help us. With type 2, we really are trying to keep it as low as we can go. And with insulin resistant PCOS patients, we're trying to keep it below 5.7 for them before they try to get pregnant, especially if it's an embryo transfer where we have control and can control transferring that embryo in.
I know you have a lot of people freaking out because 5.7 is a goal for everyone, and it is hard to get to.
Yeah, not for type 1s or type 2s. So, and I have a slide on that, but that's just for my PCOS patients that I talk to. And I have a slide that talks about the American Diabetes Association recommendations for the other ones.
Okay. All the type 1s can relax for 2 seconds. Okay. So then this was something that I struggled with. I didn't have the right gynecologist in my life. And so at that point I was trying going into 36, nothing is happening. I just was told, keep trying. Sometimes it takes a year. When is the right time to reach out to someone like you? I know my gynecologist told me when was the right time, but maybe if I didn't have him in my life, I wouldn't have known to reach out to you.
Yeah, at 35 years old, we encourage women to try for 6 months if they're having regular menstrual cycles and if their partner doesn't have erectile dysfunction or any health issues. But otherwise, after the 6 months, it's important to check your ovarian reserve, check the fallopian tubes, check a semen analysis. In women under 35 who've had regular periods and are healthy otherwise, we talk about trying for a year. After that, it's important to get an evaluation.
Okay. And then I know you touched on some things that you can do to prepare for that and some of the testing. Is there anything else anyone should know before coming to talk to you as a first-time patient? Anything that helps you?
I think it's good to have your medical records. I mean, it's helpful to see what your trend of your hemoglobin A1C's been, how's your body mass index, how's your thyroid levels been, have you had normal pap smears? If you're over 40, to have an up-to-date mammogram. That's helpful information to us.
Good to know. I think one thing that I tend to tell a lot of type 1 friends is be your own advocate. Ask lots of questions. Don't just settle for an answer. If you have questions about it, it's important when you start meeting with a reproductive endocrinologist to really dig in deep and figure out what's going on. Because if you're treated like any other patient in any other case, you might not be getting the kind of care that you actually need. Okay, so that goes into the next question. How do I find someone like you? How do we clone you for everyone else that I know?
I think wherever you are too with type 1 diabetics, the follicle size, what we have seen here is that we need to get a bigger size follicle to get a mature egg. The other thing is the mitochondria, which I have a slide about too, about egg quality with the diabetes is reliant on CoQ10 or ubiquinol, which is a vitamin that helps the energy of the eggs work better too. And then you have to, because it seems to me like Leslie said, you have to be your own advocate. Even when I was trying, I felt like I had to be my own advocate for myself too. And I mean, I know I do this job, but I was still kind of scared being in my late 30s when I was trying to get pregnant. So I think it's important to keep your blood sugars tightly regulated. It's okay to have a cheat day, but you make up for it by exercising a lot more maybe the next day, because we're all human and you have to still live your life and enjoy get-togethers and things like that. So I always tell people you can't kind of play the blame game and look retrospectively. You have to just move forward to help. That gives you a better positive mindset for the next group of eggs.
Yeah, going through this is definitely a roller coaster. So you kind of have to prepare yourself for that and can't beat yourself up every day. Okay, so going back to, how do I find someone like you? So how do I find a reproductive endocrinologist who understands a bit more about type 1? What kind of questions can I ask that would help me lead to someone like you that could help?
Sure. I mean, I think directly ask the physician. I also just, again, if you want to advocate that you've heard that having larger size follicles may get a better mature cohort or group of eggs. I think making sure the embryology lab is the best in your area is important too, that they have longevity of healthy babies for a long time, not just a new lab. I think that to me feels helpful to know.
Okay, next slide. So we talked a bit about this, but I know my protocol was a little different from standard protocols and others in the community that were going through IVF at the same time I was. So I wondered, what do you recommend as far as doing things differently for people who have diabetes?
Sure. I think it's helpful to do a mock cycle with the embryo transfer. So when you do IVF, it's sort of an 8 to 10 week process. The first process is getting good eggs and embryos. And once you have good embryos frozen, the process to put an embryo inside can either be natural ovulation, and then we put the embryo inside, or you can take oral estrogen and then intramuscular progesterone and actually do what's called a medicated cycle. some people encourage a practice run or a mock endometrial receptivity assay test. So you take those medicines for about 18 days, but we don't thaw the embryo and put it inside. We do a biopsy and check for the receptors for the embryo to implant. There's a new paper out now saying the mock cycle may or may not be necessary, but in some people, especially when we're limited on our number of embryos, it does seem to be an added tool in the toolbox to improve success. Some places use it if you've ever failed the transfer, then they'll think to try that as an opportunity to understand why potentially the embryo didn't have a chance to stick. I think with embryo transfers, we sort of throw the kitchen sink at patients. We have them take baby aspirin, prednisone, we have them take antibiotics. And so the prednisone can cause blood sugar to spike. And so it may not be as critical to have the 4 days of prednisone because maybe it's not worth the impact on the blood sugars. And again, it kind of is a case by case individualized care to figure out what to do for that.
I will say with my first transfer, I opted out of the mock cycle because I was so excited to finally be pregnant. I thought this is everything and I'm going to get pregnant and there's nothing stopping me. And so Dr. Alexander said, we should do a mock cycle. And I went, oh, no, we don't need to do a mock cycle. This is going to work. And come to find out when I actually did when that did not work out and I did a mock cycle, we found out that the day of transfer was much different than we had originally planned on. And even more different with my second mock cycle. So I think with both kiddos, I did a mock cycle before I did the transfer and they were super invaluable. So again, I totally tote that as something you all want to consider as you're speaking with someone, especially based on the number of embryos that you have that are viable. Okay, what about, oh, you talked about skipping the steroids due to, so when you were saying to maybe skip this, the steroids for blood sugar impacts, you're saying that the impact of having sky high blood sugars for 2 or 3 days before the transfer could wind up giving you a result that you're not looking for, that might be an impact.
Mm-hmm.
Okay, yeah. Got it. Okay, that makes sense. All right, thanks. Next slide.
Yeah, so let's talk about pre-pregnancy counseling. So if you're type 1 or type 2 diabetic and you're like, I might start trying in 6 months, what should I plan ahead? You want to talk to your medical endocrinologist about your target hemoglobin A1C. Make sure you're up to date with your chickenpox, measles, and rubella vaccines. Make sure you're taking your folic acid, get to your ideal body weight. Check your egg reserve with blood tests called AMH, FSH, and estradiol. You could think about the fallopian tubes. Definitely if you're in your later 30s, it may be better to know that the fallopian tubes are open versus closed and not to take too much time if they weren't open. They can be closed due to endometriosis, prior STDs, tobacco use can affect sometimes the issues too. And also with men, about a third of the time or more, we find that the semen analysis is abnormal. And some people get very frustrated because they've been trying for so long and then they realize that the sperm count is low. And since COVID now, we found that men who had COVID, their sperm DNA fragmentations altered. And so it could be good to have a checkup on the semen analysis to make sure that's a checkbox that he's good so that we don't have to jump in and help him, but while we're focusing on the woman's side. In vitro fertilization, we really need during early embryogenesis tight blood sugar control because that's what helps us avoid miscarriage. And so if I can echo that again, I think that's a really important time period for you guys. Next slide. This is a beautiful image of the embryoscope, which is it starting? Yeah. It's a video that shows how the embryos grow. Let's see if it'll play. If not, we can email it to you guys if you want to see it. But And it might be on our website too, but it basically shows over the 7 days how the embryos develop. And the one on the left did an abnormal division, and they actually could have caught that that embryo had a chromosome problem and would not have been a good embryo to put inside. And so this kind of data helps us understand which embryo to put in.
And this is so cool to look at. So my daughter Holland was one of the ones where we did the embryoscope. And so we got to see the whole process from initial creation all the way through before she was frozen. So it was kind of cool.
Yeah, it always gives me like a moment where I see it every day. So it's so interesting. Well, so in terms of maternal hyperglycemia, like I mentioned, hyperglycemia can cause congenital anomalies or early changes in embryo development and embryogenesis and create reactive oxidative species, which can affect the spinal cord development and especially also cardiac issues for the heart's development. So another reason to just be cognizant of that.
And I know our doctors talk to us all the time about how important blood glucose control is, but I don't know that anyone has ever spelled this out before I met with you.
Yeah, I think, yeah, because some patients, one of my patients, I remember fondly, once a week, she would always want like a big sundae and eat that. And that was okay, but it took like 3 days for her sugars to get tightly controlled again. So I was telling her, get through the first trimester, which is when the heart forms, the spine forms, all the key things form. And then after that, you can have a little more leniency on your nutrition after that. The menstrual cycle is really important. There are studies showing that in type 1 and type 2 diabetes, the menstrual regular cycles is a little off kilter sometimes. We want your period between 28 days or so. We also don't want you going longer than 40 days apart because the building blocks inside the uterus get a little too thick, and that can cause endometrial hyperplasia or pre-cancer inside the uterus. And it can also cause little skin tags or polyps that can pop up in there. The other thing about your flow is you want to have a good flow, like a full day of full flow. When people say the period's very dark and not like a good flow, I always worry that the estrogen is low. And so if your estrogen is very low from being too thin or overweight, that can also impact the ability of the embryo to stick inside the uterus for natural pregnancy, for spontaneous conception. Next slide. And like I mentioned, there are some menstrual abnormalities, and there are some papers showing recurrent pregnancy loss. And so it's important to get checked for that. Some young girls who get diabetes pre-puberty can have delayed menarche or delayed menstrual cycles starting. They can have premature menopause. Some people can have their period regularly until they get into their 20s. Then suddenly their period doesn't come for 6 months. That's called secondary amenorrhea, and that can be due to anti-ovarian antibodies. And key point is to have tight glycemic control and to improve your menstrual cycles with natural progesterone. You can talk to your gynecologist about that. Not everybody has to just be on a birth control pill, because if you don't want to be on a birth control pill, you can take 10 days of natural progesterone or prometrium to help shed the lining and keep your period regular without being on oral contraceptive pills. And as we talked about tubal disease or the fallopian tubes, which is the ability to catch the egg, and the picture on the right is a fallopian tube that's kinked off by scar tissue that can be from endometriosis, prior appendicitis, as well as pelvic infections. And the picture on the right is called hydrosalpinges, or fallopian tubes that are quite swollen, and those actually have to get removed before an embryo transfer can be done. Next slide. And we mentioned earlier the mitochondria, which is the energy of your eggs. And there are studies looking at maternal diabetes causing mitochondrial dysfunction or irregular function. and it can affect the chromosomes separating because the mitotic spindle relies on the energy of the mitochondria, and that can also take an extra piece of a chromosome, which can cause Down syndrome or chromosome problems. And so that may be contributing to miscarriages, or people who say, I swear I got pregnant, I had a positive pregnancy test, then it turned negative, and I never got to see a heartbeat or anything. And that's called recurrent biochemical pregnancies, where the egg fertilized and the embryo tried to grow, but it didn't continue. And you could talk to your doctor about that too. Next. So when the embryo gets into the uterus, that's where this is really also important, because certain regulatory receptors have to be there to bind, so the embryo can bind and stick. And like Leslie mentioned, the timing for that can be detected with what's called a mock endometrial receptivity assay. I don't know if you have any comments about that. And I remember how you were so vigilant on the day of the embryo transfer to be so good with your blood sugar.
Yeah, and I think that was such a key thing to do this testing for me. I, had endometriosis. I kind of went into forced menopause before we did the transfer, and doing the mock cycle to make sure that everything was clean and ready to go. I didn't have any polyps. It was a whole thing, but I think that testing really led us to, obviously, the perfect time to transfer the embryos. And then not only that, but having perfect blood sugar control. So I remember the day that we transferred Elliot, I believe my blood sugar was hovering around 60, and I'm like, oh, I'm good to go. I'm good to go. And you said, no, we're waiting until your blood sugar comes up. We're making sure it's ideal, because we're not wasting all this time and energy to have something happen outside of our control. So we're going to wait, and I'll be right back.
Yeah, we wanted above 70 on the day of the embryo transfer. Yeah. So that was good. Good job with that.
Yeah, thank you.
Next slide. Yeah. So like I mentioned, in terms of high blood sugars in that early embryo development stage, the first 10 to 12 weeks of pregnancy, it is a known teratogen, so it can injure or hurt the early embryo developing. And these are the pathways. This is kind of a little molecular, and if there's any people who want to understand these, but these are little issues that can be culprits of anomalies. And so it's important to understand the mechanisms for that. Next slide. So neural tube defects can be prevented with folic acid. We really want you to be on folic acid 3 months before you try to get pregnant. And so I gave a talk to endocrinologists, and I was telling them, if you have a patient who's not on contraception and may get pregnant, don't let them not take folic acid. It's important to take it 3 months prior to getting pregnant. Also, folate supplementation may mask B12 deficiency in women with type 1 diabetes, because they can have autoimmune gastritis. And so it's important to check B12 levels. So you have to be your own advocate. So sometimes in the hustle of focusing on your glucometer and looking at all those, your sugars and stuff, they may forget this kind of a thing, but it's important to think about it.
Is there a difference between folic acid and folate?
Yes. Some people have a genetic thing called MTHFR, and their stomach does not absorb folic acid. It only absorbs folate. And so they have to take methylated folate, not folic acid. It runs in some people's family. So what I lately have been doing is I have patients take their prenatal vitamin with folic acid, and if they've had recurrent miscarriages, I'll add 1 milligram of methylated folate, and that seems to dodge the miscarriage issue.
Okay, good to know.
Next slide. So this is kind of an important picture, because when I have some patients who, maybe aren't being as cautious with their diabetes, I just show, it's always kind of a little bit mind-blowing to see, but the spine didn't form properly. And so this is called sacral agenesis. I've seen this once when I was at Johns Hopkins. And so it's important to think about this, but this is a severe version of a spina bifida issue, and this is preventable. And so it's important to keep good blood sugar control beyond the folic acid, and especially if you're thinking about trying to get pregnant, to plan ahead. So why in the second and third trimester does insulin requirements go up? I also think this is so fascinating. I know it's a lot of minutia, but the placenta, especially if we have twins, produces a hormone called human placental lactogen, which makes women extremely insulin resistant. And so that can cause women to get gestational diabetes, or if you have diabetes, for it to require more insulin, especially as the placenta gets bigger and the baby gets bigger. The one caveat is in the first trimester, there are fainting spells and there are risks of hypoglycemia, especially if you're driving. So you always want to be a little careful. I think now with your guys's monitors, it's much less risky because you get alerted if you're going to start to go low. But in the old days, some patients would pass out with the hypoglycemia in the first trimester. That's how some people figured out they were pregnant, is that they would have those things happen to them.
I definitely had some of those lows, and thank goodness for my CGM. I couldn't live without it, but it alerted me right away. But no pass outs, thank goodness. But I know that that's an issue that a lot of people have.
Yeah. Next slide. And so why do recurrent pregnancy loss happen? I think of it in categories because that gives my mind kind of a detective system attack. So we think of it as genetic. So if the egg and sperm connect and there was an extra piece of a chromosome, that's the most kind of common reason that a miscarriage happens. Then the other reason can be inside the uterus. There can be polyps, fibroids. There, if you've had a prior DNC, there can be scar tissue in there. There can be adenomyosis, which is endometriosis in the uterus. And so it's important to talk about that. Thrombophilias are blood clotting disorders. Sometimes it runs in our family. So if a patient says their dad had a stroke or their grandma had a stroke at a younger age, we can check for factor V Leiden, prothrombin gene mutation, and other genetic mutations that can run in your family. Immunological issues such as antiphospholipid antibody syndrome is an acquired issue, so it can happen over time. Some people say, I had 2 healthy kids and I was trying for a third, and then I was having running into all these problems, and that can be an immunological issue. Endocrinopathy is thyroid, prolactin, if your hemoglobin A1C is not as tightly regulated as it could be. Infectious can be little bacteria in the vagina called ureaplasma mycoplasma that can disrupt the embryo from implanting. And then idiopathic is unknown. So some patients, they're perfect hemoglobin A1C, their thyroid's on target, all the testing's perfect, and we can't really find a culprit. Next slide. In terms of the placenta, it is an important thing to think about. When I think of the placenta, I think of 2 important things in any patient who's pregnant. Number 1, I want good blood flow. So if a patient says, I work 12-hour shifts, I never sit down, I'm always on the go, I never, really get an opportunity to lay down, I always think the blood flow to the uterus is a little bit less strong. So if you can, on your breaks, to lay and take it easy so that especially in the second and third trimester, you get good blood flow to the placenta. The other thing about type 1 diabetics is over time, the teeny blood vessels, especially in our eyes, our kidneys, to the uterus, they start to get a little tired. And so there's a little bit of endothelial dysfunction. And so the actual blood flow to the uterus may be a little hindered. And so then the placenta is like, come on, give me some blood. And then the uterus is not as robust in doing it. And so it may be important to think and monitor the pregnancy a little more carefully so that there isn't intrauterine growth restriction. Next slide. And the American Diabetes Association does say to prevent spontaneous miscarriage, you want to target your hemoglobin A1C. Again, like Leslie mentioned, there's no perfect number because different with type 1s. I know from talking to my own family members, it's not easy for some people to go below 8, but you can try your best. And then with type 2s, you usually can at least try to get into the low 7s. And remember to keep an eye on your thyroid function, especially with type 1 diabetes, because pre-pregnancy thyroid dysfunction can increase risk of spontaneous miscarriage. Next. So I mentioned about the egg retrieval. So if you get to the point with your doctor that you might need to do IVF or in vitro fertilization, you may take 10 to 12 days of medications. And as that 10 to 12 days goes by, we monitor you with the ultrasounds. There's about 5 to 6 ultrasounds. And then we do a small procedure called the egg retrieval, which is done through the vagina under light sedation with a teeny needle. And we carefully get the eggs out, and then we fertilize the eggs. Next slide. So this is a picture of how we get the eggs out with the transvaginal probe with a thin needle. We go through the skin of the vagina into the ovary. And it's important to check with your facility to see their success. We work really hard here as a team to optimize and get the best success that we can. In our patients under 35, we've been blessed to be towards 80% pregnancy. And as time goes by, it goes down from there. But what we have found is that if we can get a genetically normal embryo and we do all our prep tests, we can get over 70% of patients pregnant with a genetically tested embryo. In our patients under 35 years old, it's up to you individually if you want to check for genetics of your embryos, because there's kind of an ebb and flow of the scientific data, whether when you're under 35, if you have to check the embryo. If your partner is over 50 and you're under 35, it still may be helpful to have genetic testing for your embryos.
I remember my first question about the genetic testing is, can we find out if they're going to have type 1 diabetes? I think that was my first question I asked you about it. Unfortunately, no, right?
I know. Yeah.
I know. One day, maybe.
Yeah, I know. I think it's polygenetic. So it's not a very clear one gene that causes it. It's
Right.
many different genes and environmental factors that click into place, and then it causes that. So,
Yep.
Yeah. Next slide. So just in conclusion, I think it's important to talk about your pre-pregnancy goals and get to your body mass index that you can do, exercise, eat right, and protect our pregnancy from fetal malformations. There's always ongoing research. I think there's even newer discussions in pregnancy of which type of insulin to take, what's the best way to keep your blood sugars under control. And I think it's a collaborative effort. So we work closely with the endocrinologist, maternal fetal medicine. We work with your OBGYN. It should really be a lot of people putting their minds together to keep an eye and check on you.
That's one thing I loved about working with you. I knew that you had my back and you would reach out to my endocrinologist if needed and reach out to my gynecologist or MFM. And I always felt well taken care of. So I always appreciated that. And I would hope that everyone listening would find a doctor that feels the same way and wants to do it as a team collaborative sort of thing.
Yeah, I think it's, to me, that's what I would want. And that's what I think is really important. Next slide. So here at SCRC, we're a group, we're expanding. I think it's been such a joy to work here. We always are reading articles and trying to stay as up to speed as we can. And we are happy to take care of you. All of us see new patients. We do a lot of it on video calls now since COVID, and that helps patients because they don't have to park and hurry in, and you can talk for 45 minutes without having to wear your mask and goggles and all that. Yeah, next slide. And if you would like to schedule a consultation, if you mention diabetes October webinar, you get half off the consult. And I'm happy to answer any questions today too. Thank you, Leslie, for joining in today.
Thanks, everyone. Thank you for having me and allowing me to be a participant. Thanks.
I don't think we have too many questions, so that's good. We answered a lot of patient questions from the beginning, so yeah. Well, thank you so much for participating, and I look forward to giving you a real hug in person and seeing
Absolutely.
you soon.
Okay. Thanks, everyone.